Level and the Vice President of Communications and Public Affairs. Welcome today to our town hall, hospital-wide update for our staff and physicians. Today we don't have large presentations to make or big announcements, but we are going to deal with some questions that have been coming through the staff line and some of the current pressing issues that we're dealing with as a hospital system throughout the pandemic and otherwise related to our day-to-day operations. So I don't want to waste any time. We have 30 minutes for today's webinar. We're going to field some questions from all of you. Thank you for attending. So I'd like to invite our President and CEO, Rob MacIsaac, to give us a bird's eye view of our current state and where are we at. So Rob, over to you.
Okay, thanks very much, Aaron, and good afternoon, everyone. Thanks very much for tuning in to the town hall today. As Aaron said, I've got a couple of brief updates and then we'll open it up for any questions you have regarding either what we've talked about or other things. If we don't get to your question, just acknowledging the timelines are tight, please send it to hhsnews@hhsc.ca and we will post a response to your questions on the hub. Before we turn to questions, I'm happy to report to you that our service reintegration plans are moving along well. We're continuing our ramp up of activity. We're continuing to prioritize patients who have the most urgent needs. We've also been stressing to those waiting for their procedure or appointment that our emergency and urgent care services remain open and safe for unexpected medical needs. I want to say thanks to our many teams and departments for supporting our patients and their families as we work gradually to welcome them back to our hospitals. I think your compassion and your patience make such a nice difference for them. I know that pandemic pay remains an important topic for many of you. And we've been vocal about our advocacy for expanded eligibility amongst hospital staff. And to date, unfortunately, the provincial government has stood by its original position. So we'll continue to advocate on behalf of those staff who are not captured within this plan. I also want to say that we're continuing to wait for the actual funding and guidelines from the province for those who are eligible for pandemic pay. We'll make sure to issue those funds to eligible staff as quickly as possible once things become clearer. I know, or I've heard rumors that other hospitals are already paying pandemic pay to their staff. In fact, there was a rumor at St. Joe's that HHS staff were already getting their pandemic pay. I'm not aware that there is, in fact, a hospital making such payments already. I do not believe there is. I appreciate your patience and understanding as we navigate this situation. We will all continue to talk to hospital peers across our region, across Ontario West, and across the province to make sure that HHS is not in any way an outlier with regards to this. I'm very pleased to share with you that the outbreak on our COVID unit at Hamilton General 8 West has been declared over. This has been a really concerning event for both staff and leadership at Hamilton Health Sciences. And we are doing our best to learn from what happened to avoid any repeat situations from occurring if at all possible. Thank you everybody for remaining vigilant and helping to protect yourselves and one another from the spread of COVID-19. Finally, I'd like to acknowledge the conversation and advocacy that has been occurring in recent weeks related to anti-racism. Last week, our hospital publicly expressed our support for the Black community and our commitment to making HHS a safe, inclusive space for everyone. That said, actions are certainly louder than words. And I think, Hamilton Health Sciences has, in fact, done lots of things that speak to our commitment to this. But that work is not finished. And we've asked our staff, patients, and our community to tell us how we can do even better. We've received a lot of emails, and I want you to know every message has been read, and each will influence our thinking and our actions moving forward. Our human rights and inclusion team is compiling a report based on this feedback for me and for our executive leadership team. As I said earlier, I think we have a good record of work to date in regards to diversity and inclusion initiatives, but we are committed to continuing along this path. On behalf of our leadership team, I want to express my commitment to keeping the conversation open and to taking concrete actions to eliminate racism in our organization. So stay tuned for more, and please don't hesitate to share your feedback with our human rights and inclusion team at inclusion@hhsc.ca. inclusion@hhsc.ca. With that, I will turn it back over to Aaron Levo, who is going to moderate our Q&A sessions and the remaining topics we're dealing with.
Thanks a lot, Rob. So I have some questions that are carryover from emails that we've received from all of you out there in the workforce, and I thought I might ask those first, and then I can already see some people writing into the Q&A and chat forum, which is excellent. Hopefully we'll get through a good number of those with the balance of our time, but if we don't, as Rob pointed out, you can always expect an answer from us after the fact. So I guess first, let's start, Dr. Dominic Wirtz, this question is for you. Why are all patients not tested for COVID on admission? Testing's a hot topic province-wide. Why don't we test everybody as soon as they get here? Dominic, you might be on mute if you're speaking.
Sorry about that. So thank you, Aaron.
No problem.
Yeah, it's one of those evergreen questions which come back over and over again, and I cannot count anymore how often we addressed this question already, so I'm more than happy to share it with hopefully a large audience today. And I put together, just to make it easier to follow, a couple of slides to sort of underline the thinking. Just the numbers here are days, day 1 to 40, and 6 possible scenarios of patients that we deal with. We have the newly symptomatic patient who comes in, who will test positive, is infectious for 8 days, so that's the red bar, would continue to test positive, typically for a couple weeks, 3 weeks. We've seen it up to 8 weeks. This being said, they are infectious for 8, maybe up to 10 days, mildly symptomatic patients. After that, you're still positive when you test, but you're not considered infectious anymore. Then we have the pre-symptomatic patients. These are the ones we are most concerned about, which don't have symptoms yet, but already transmit the virus. And that's up to 48 hours before onset of symptoms. So that's the orange here. And they typically test positive in that pre-symptomatic phase of 2 days, would continue to test positive while they are symptomatic. Then they are symptomatic and infectious. And then you, again, switch into NPS positive but not infectious situation. Then you have the post-symptomatic patients, which continue to test positive but aren't infectious. You have asymptomatic patients, which, depending on where they are in terms of when their onset of being asymptomatic carrier is, may be infectious or not. Most of the evidence points towards a lower risk of infection, but there is some risk for sure there. And then we have the newly asymptomatic patient who comes in asymptomatic and negative and at some point switches to positive. And you have the patient who's incubating and maybe develop or may go into the pre-symptomatic phase in a couple of days, those would test negative upon admission. So if you go to the next slide, based on what I just said, the only group that we are really concerned about when we consider testing asymptomatic individuals, either everyone or with the next step that we will take, discontinuing testing pre-procedure and pre-surgery, and following the new provincial guidelines, the ones we are really concerned about are the pre-symptomatic patients. So let's focus on this group and go to the next slide here. Looking at our current epidemiology in Hamilton, we are at, on average, 5 new cases per 580,000 population. Even if we assume that we only see 10% of the iceberg by testing, that would translate into maybe 50 new cases per day, or 8.6 per 100,000 population. Now, if we say we get a random sample from those on a given day, and we have that 2-day window to identify people who are pre-symptomatic, so those 48 hours, that would translate into 17 in 100,000 admissions, or 0.017% would be pre-symptomatic when you test them upon admission or before surgery. This translates into a number needed to test to identify one single case of 5,882. Now, if we assume a specificity of the test of 99.9%, we will have far more false positive than true positive tests. So we will have at least 10 who test falsely positive to identify one true positive test among 6,000 individuals. And that's the rationale why there's no added value in doing that kind of testing in a low prevalence setting, like we are right now. This being said, in a second wave with much higher case numbers, this assessment may change, and maybe there is a value in doing that, but certainly not in the current setting. Okay,
thanks, Dominic. I wonder if I have a follow-up question. I wonder if I can put it to you about checking temperatures at the door. In terms of staff and patient screening at the doors, like why is that not currently a practice? And I think it's being done elsewhere, but not for us. Does it have anything to do with who's taking the temperature, or what's your observation there?
Yeah, and another question that I've been asked several times over the last weeks and months. So let's start off with the scenario. So you have patients, staff coming in who have fever and symptoms. So everyone who has fever and symptoms is supposed to stay home anyways, unless they lie to us and they don't tell us about their symptoms, they wouldn't come in. And then you have a very small proportion of people who have fever as the only symptom. So this being said, in non-hospitalized patients, less than half of COVID patients have a fever. And isolated fever, so fever as the only symptom, is very rare. So these are the ones that we would potentially pick up. So only fever, hasn't realized that they have a fever and didn't want to hide that fever. These are the ones that we would pick up with temperature measurement at the door. And again, if someone really wants to hide the fever and the symptoms from us, they can take acetaminophen before they come in, and they will probably not have a fever when they come in. And the other big issue is what's the magical cutoff that you use for fever? So say you use 38. The margin of error for most of those thermometers that I looked at is between 0.3 and 0.5 degrees Celsius. So if you say the cutoff is 38, you may be picking someone up who has 37.5, and that could be me running to work or biking to work and haven't cooled down yet. Or it could be someone who has a true fever. On the other hand, someone with 38.5 may not be picked up because of the lack of accuracy of those thermometers or tests. So in the end of the day, I know there are many areas where this is being done, and I think from an optics perspective, it reassures people a lot. They feel, oh, it's a safe place because temperature is being measured. But when you're looking through what you actually want to capture and can capture, again, it's probably resulting in more errors than actually added value. And that's why many institutions have decided against that approach.
Well, thanks for that clarity. Switching gears entirely, next question is about our parking lots and entrances in our parking lots. Maybe Kelly Campbell, I can ask you to weigh in on this one. Just about the entrances in the parking lots, and with the increasing amount of traffic, there's an increasing amount of people going in and out of those entrances. How managing that? Is there any way to change how those entrances function?
Site issue. Screening is not done in the parking garages at any of our other sites. So I assume the person asking the question is from the Mumsy site. Certainly we are looking at this, and we have made some recent changes in the parking garage to improve safety. At the same time, trying to meet parking demand as our services start to ramp up. So stay tuned. We're really looking at some options for staff screening that will get us out of the parking garage. We will continue to have to screen patients and visitors in that way for some time, but at least if we can get one group out of the parking garage, that will help a lot.
Thanks very much. Next question, I'd like to ask about the return of research and learners into the organization. I know I've been privy to some conversations about taking a phased approach to reintegrating research and our learners. This is in addition to the ramp up of clinical services. Dr. Michael Stacey, maybe I could ask you to comment a bit about what is that phased, what would people expect to see over the coming weeks and months in regard to this issue?
Yeah, thanks, Aaron. I guess as everybody knows, learners and research are a really important part of our organisation, being an academic teaching hospital. Clearly, they're a big part of the function that we have. However, during this COVID pandemic, we have very much closed down access to the hospital to learners, and for research, virtually everything except COVID-related research has also been closed down. So groups have been working actively to look at a very gradual staged plan to bring learners back into the organisation, and Kirsten Kroll, in combination with Azim Ganji from St. Joe's and all of the clinical programs that have learners in our organisations, have been carefully looking at this, looking at a very, very gradual staged program, making sure that there is alignment with the principles of social distancing and the use of PPE, and also trying to maximise as much as possible virtual learning opportunities. So there is a gradual program planned. Some of those learners will come into the organisation next week. We've had a few PAs this week, I think. But there'll be very close monitoring of that, so that if it is causing issues, then obviously we may need to pause. As far as research is at the stage of any research that can be conducted virtually without having to come into the organisation is being conducted. The next step will be to look at bringing back some research that involves patient groups that are already within the organisation, but limiting as much as possible introduction of other staff, such as research coordinators, into the organisation, but gradually allowing them back. Once again, aligning to all those other principles of social distancing and being very alert to the impact of this on our PPE supply. So we will start to see that gradually over the next month, but it'll be a very slow process throughout the course of the rest of this year. Kirsten may want to comment briefly, but
Thanks very much. Well, actually, my next question, I thought I might ask to Kirsten too. We've been getting a number of questions at the email inbox about the resumption of CQI, our continuous quality improvement processes. Now, for sure, in a lot of areas, that work has probably not been as deeply impacted. For those that are remote working, though, some of the face-to-face occurrences can happen. Some of them have perhaps been paused. Organization-wide, what should we be thinking about in terms of resuming our CQI processes full throttle?
Yeah, thanks, Aaron. And a lot of people have tried to continue with our CQI huddle work. Certainly lots of disruption over the last 3 months. but we highly encourage areas to get back to those norms again. It's a really important part to connect as a team, which we all need a lot of contact with each other these days. So it's good for our health, but it's also great for our problem solving. We want people to get back to their huddle periods. Again, we're really going to try and encourage people to try and protect that time slot, which was always the sacred 8 o'clock to 10 o'clock in the morning as an organization, really trying to allow people to be in the workplace, leaders to be with their teams, and really having that touch point with status sheets and huddle experiences as well. We know not all areas do that work right at between 8 and 10, but a lot of areas are, and we really want people to get back to their norms. We have seen some areas who have been using their huddle process and improvement work to actually attend to some of the COVID-related issues. As an example, how to connect with patients and families, or with families of patients, but also issues that had arisen around PPE or other issues in their processes. So use that platform for continuous improvement. And again, the virtual technology is continuing to be a good mechanism for people to connect, even as teams or leadership teams, as they think about how are we looking at our overall performance, how are we gauging our indicators of success, and how do we get back to really identifying what are our priorities right now. We're trying to move to a different kind of norm again. Kind of COVID peak has kind of coming to an end. That work, I mean, but it's now how do we establish a new norm. So this is a great time for people to use those mechanisms again. And be curious about what's happening in the organization, looking upstream and downstream with different teams as well. So the beauty of Zoom is that it allows us to still do those connections. So highly encourage it.
Wonderful, thanks for that. I do have a couple of questions right now in the Q&A forum around pandemic pay. Maybe Dave McKay, you could take a stab at these. One's about the financial impact of paying out the pandemic pay if it's honored to all. How would that impact sustainability efforts at HHS? And the second being about those that are eligible but might be working from home, would they still receive the pandemic pay? Don't know, maybe you can comment on that first.
Sure, thanks, Aaron. So to the first question, we have yet to receive all the detailed information that would be coming from the government in terms of exactly how to apply pandemic pay and how that will work. But the government has been clear that funding will only be provided to those for which they deem to be eligible under the program. And that's it. So hopefully that answers the first question. The second question, if an employee is eligible, hours worked is what would be used. It wouldn't matter what the location was. So if you were redeployed in some fashion, or even in a role where it was eligible for pay but working off-site, I believe you would be eligible. So again, we do need to receive all of those details from the government. There'll be, as you would imagine, a fairly detailed package of how it would work, as well as the funding that the hospital would receive, would all come to us at that point in time. That is still outstanding.
Aaron, I might just add to what Dave said, that there is a number of different pieces of legislation that have been passed around wage restraint. So I think it's not even clear to us at the moment whether or not it would be legal to go beyond what the province has suggested. So I just think it's an important fact to state. It probably transcends some kind of future penalty and really goes to the legality of doing it at all.
Thanks, Rob. That's correct. There's a lot of directives and legislation that all impact compensation right now in the overall health sector, and you're absolutely correct.
Dave, well, I got you in the hot seat. Maybe I could also ask two questions in the question forum, and I know it's come up in our email box. Any insights about the return to work? And others might want to comment too from our leadership team, but how are we going to make decisions about returning people who are currently working remotely and reopening, in particular, our administrative office space, which has been closed down to respect physical distancing? Where will we be taking our cues?
Thanks, Aaron. So a couple of things I could say. First off, always taking our cues from the province in terms of what the expectations are for reopening and getting back to some fashion of normal. In terms of our space, however, Kelly Campbell, who's on the call, you might want to add something, Kelly, but Kelly is just beginning to form the group and lead work to look at how we would accommodate appropriate protocols to be able to bring people safely back to work, what that would look like. And she'll also be including appropriate leaders from the different groups. So it is something that has started to be worked on. So imagine 3 people can be on an elevator, no more. How would we do that? How many people could we physically accommodate in the space? What roles? How would that all work? So a lot to figure out. And we want to make sure that we do it properly and in a way that accommodates all the requirements of the organization as well. So more to come on that, but you can imagine that's going to take several weeks to work all of that through and deploy any changes that we need to. So Kelly, I don't know if you'd like to add anything or if that covers it.
Very thorough response, Dave. I guess I would just reinforce, you're right, we're going to take our cues from the province. And we know large office buildings like King West are later in the phasing of reopening. So we do have to look at all the things you talked about. 300 people cannot come back to King West at one time and hope to maintain physical distancing. So we're going to have to look at some kind of phased approach, working with the leaders at the site to understand how we would do that. So yeah, stay tuned. Lots of planning to be done.
Thanks very much. So I'm conscious that we are at time. I know there are questions still in the Q&A. I just want to call out about the geriatric rehab unit, about parking and pausing parking fees, and also about the commitment of the senior leadership team to addressing anti-Black racism at Hamilton Health Sciences. So we'll get to those questions. We'll do so through the hub format as we have a firm stop at 2:30 today. But thank you. I want to acknowledge that those are there and encourage everyone to continue to ask questions as appropriate at the HHS News at hhsc.ca email address. Additionally, if you do have any celebrations, we've cut short our agenda today and omitted our celebrations component, but if you do have any celebrations you'd like to make, equally email those to that same line, and we'll make sure that we do that in a fashion either on the hub. I'd also encourage you to think about using our social media channels. Maybe on the HHS staff Facebook page is a great way to recognize your colleagues or someone that you think has gone above and beyond and call that out. Anytime. Those kudos are always nice to get and don't have to necessarily be in this forum. But if you do send something along to that line, we'll try and make sure that it gets noticed through those channels as well. So maybe closing remarks from you, Rob, and then we'll call it a day.
Yeah, thanks, Aaron. Thanks, everybody, for attending. I know we're almost out of time. We will try to make sure we do it, save time in future for the celebrations section. I know it's a part of the agenda that people really like. I do want to give a shout out to all of the staff and the team supporting 8 West over the course of the outbreak, and just I think it's been wonderful, hard work, and we really appreciate all that's been done and celebrating the fact that the outbreak is over. So with that, I'll wrap up and say until next time, thanks very much for attending, and we will continue to do these regularly. So cheers, everybody.